which tongue appearance is shown here, then this is a magnetar tongue. Lot of guys, they casually answered as strawberry tongue, but this is a magnetar tongue. You can see the color of the tongue is purplish, and this is due to vitamin B2 deficiency. So it is B2 deficiency which is responsible for magnetar tongue. For the diagnosis, if you look at the manifestations in the first figure, you can see bulbar congestion, fever for 5 days. That's again a hint, fever for 5 days. Then there is bulbar congestion present in the patient. The second feature that is present here is you can notice here desquamation. There is a periungual desquamation occurring. Periungual peeling of the skin is seen. There is a periungual peeling of the skin. I can mention it here. Peeling of the skin is occurring. Peeling of the skin is a feature that is always seen with respect to patients who are having Kawasaki disease. Then you can see cervical lymphadenopathy, unilateral cervical lymphadenopathy. Then you can notice strawberry tongue. So considering all the possibilities in the question, the correct diagnosis of this question is alpha. Scarlet fever will show a rash which is all over the body, and there would be bilateral lymphadenopathy in scarlet fever. Here there's a unilateral lymphadenopathy, so pretty straightforward our diagnosis. A child presents with the following appearance, that is seborrheic dermatitis, hepatosplenomegaly, pancytopenia. Well, the initial presentation would make it sound like the child is having a blood cancer, but then if you look at the skull of the patient, you can see these huge craters which are formed here, these craters in the skull of the patient. So these craters which are formed here, this would be called as a geographical skull. This would be called as a geographical skull. And whenever you read about this statement, geographical skull, the disease which has to come to your mind is histiocytosis X. You can also notice the unilateral proptosis in the patient, that is also seen with histiocytosis X. Initially, when I looked at the theory, it looked like a blood cancer, hepatosplenomegaly, pancytopenia. In a late presentation could have been myelofibrosis, for example. But then because the question was mentioning information of X-ray skull and there's a geographical skull, so the diagnosis is okay. So the diagnosis is geographical skull. This would be a clinical presentation of what we study as histiocytosis X. Pepper pot skull is a feature that is seen with respect to hyperparathyroidism. Hair on end appearance is thalassemia. This is hyperparathyroidism. Hair on end appearance, this is a feature that is seen with thalassemia. And with such an extreme presentation in the patient with unilateral proptosis, seborrheic dermatitis, hepatosplenomegaly and pancytopenia, this is definitely not artifacts in the skull. So there is something sinister. I can just put it like this, that if you get an X-ray skull, there can only be 3 possibilities in a question. Either it would be LATIC punched out lesions of multiple myeloma, or it would be hair on end appearance, or it would be geographical skull. Geographical skull is a feature that is always seen with histiocytosis X. A 65-year-old rickshaw puller has presented with development of lump in the left supraclavicular area, so fairly a big lump here. This is the left clavicle of the patient. This is how it will be, the left clavicle of the patient. And there's a lump in the left supraclavicular area, so I am gonna call it Virchow's node, or I'm gonna call it Troiser sign. The swelling is about 10 to 5 centimeter, firm in consistency, non-mobile, which like cancer is most likely to metastasize to this area. So it would be GI malignancies. That would be carcinoma stomach is most likely to metastasize. This would be a Troiser sign in the patient, and carcinoma GI malignancies are usually responsible in testicular cancer. Here it's written CA penis, not CA testis. So that's the point why CA penis has been ruled out. CA penis goes to inguinal lymph nodes. Identify the condition. They give an image like this. You can notice a big cystic sac present here. This big cystic sac, this is a diagnostic of myelomeningocele, which is a neural tube defect which is seen and is causing flaccid paralysis of the legs of the patient, can be associated with Arnold-Chiari malformation. There is no mention of myelomeningocele in the MCQ, so on careful reading you will call this spina bifida aperta. Spina bifida aperta is a term which encompasses 2 things, that is myelomeningocele and second would be meningocele. These are two features which are to be remembered for spina bifida aperta. Craniorastasis, choice number C, is the most severe neurotube defect. Craniorastasis is the most severe neurotube defect. It is a combination of two things. In craniorastasis, you will be having anencephaly, and the second feature that is seen is myelomeningocele. These are two complications which are seen with craniorastasis. This is a manifestation of craniorastasis. This is the most severe neural tube defect. It is a combination of anencephaly plus myelomeningocele. And anencephaly, there is a cranial word missing, so this is anywhere ruled out. A choice of the MCQ, sacrococcygeal teratoma, that will present with a solid mass and that will be originating much more lower. So this is a cystic swelling at the back at the lumbosacral spine, so that's why the answer is myelomeningocele. This is again an image that shows encephalocele. There's a swelling at the back of the head of the child. This is again a neural tube defect, and the child will die not because of any infection but because of raised HCT. Nursing is to be done in prone position. You can already see the atrophy of the skin developing, and this could be resulting in even rupture of the lesion and intracranial hemorrhage. Lemon sign in Arnold Cherry malformation, just shown here because it was asked. Lemon sign is seen in AC malformation. Arnold Cherry malformation from internal medicine to be remembered is Arnold Cherry malformation type 1. There are 4 types of Arnold Cherry malformation. Type 1 Arnold Cherry malformation is the one which is responsible for development of syringomelia. Whereas Arnold Cherry malformation type 2 is the one which is responsible for development of congenital hydrocephalus. I repeat again, there are 4 types. 3 and 4 are not compatible with life. 3 and 4 are not compatible with life. Or type 1 I'll mention again. A bit of handwriting issues, I would say. Arnold Cherry malformation type 1 is associated with syringomelia, where you have dilatation of the central canal of the spinal cord. And Arnold Cherry malformation type 2 is associated with the development of congenital hydrocephalus. Frog eye sign is again a question asked. Frog eye sign is seen in, that is anencephaly. So neural tube defects were asked. Folic acid deficiency. Mostly in internal medicine, we find that if a woman is using anti-epileptic drugs, then valproate and all other anti-epileptic drugs, they can cause folic acid deficiency, and therefore they can be a development of neural tube defects in the baby in future. The safest anti-epileptic drug in pregnancy is lamotrigine. That will have the least incidence of development of neural tube defects. These were a couple of miscellaneous questions that you need to remember.